Have you ever stopped to think about how sometimes the smallest parts of our body, the tiny little components, can actually have the biggest impact on our health?
It's true. Often the ones we don't even think about.
Exactly, like
Oh,
the
yeah.
unsung heroes in our endocrine system. They control so much, and when they falter, well, the ripple effect can be huge.
Mm-hmm.
So today we're taking a deep dive into one of those conditions, hypoparathyroidism.
Right.
And our mission here, is to take all this detailed info we've gathered, notes, sources about this condition,
Yeah.
and really pull out the key nuggets. Make it easy for you listening to grasp the definition, causes, symptoms, diagnosis, treatment.
Without getting lost in the weeds of medical jargon.
Exactly. We want you to walk away feeling really informed.
And hypoparathyroidism, it does sound complex, maybe a bit daunting.
A little bit, yeah.
But honestly, the core ideas are pretty intuitive once we start to unpack them. We'll guide you through it piece by piece.
Okay, great. So let's kick things off right at the beginning then. What exactly is hypoparathyroidism, just at its most basic level?
Okay, so basically, it's a rare endocrine disorder. It means your parathyroid glands.
Those tiny ones in the neck, right? Near the thyroid?
Exactly. 4 of them usually, tiny, like grains of rice. And in this condition, they just aren't making enough parathyroid hormone PTH.
Okay, not enough PTH.
Or sometimes none at all. And this deficiency, this lack of PTH, it directly leads to low calcium in your blood. That's hypocalcemia.
Low calcium, got it.
And at the same time, high phosphate levels, which is hyperphosphatemia.
Okay, so low calcium, high phosphate.
Right. And that imbalance is really what causes all the symptoms and problems we're going to talk about.
That makes sense. PTH is clearly a big player in managing calcium. Now, this is where it gets really interesting for me. What actually causes this hormone to go missing or be too low? I think I read there's one main reason doctors see.
You're absolutely right. The most common cause, by a long shot, is something called post-surgical hypoparathyroidism.
Post-surgical.
Yeah, it happens after surgery in the neck area, so things like a thyroidectomy.
Removing the thyroid gland.
Right, or even a parathyroidectomy,
Right.
where they're operating on the parathyroid glands themselves, or sometimes more extensive neck surgery, maybe for cancer. And during these operations, those tiny parathyroid glands, or sometimes just their delicate blood supply, can be accidentally removed or damaged. It just shows how closely packed everything is in there.
Wow. It's that vulnerable.
It really is. But, while surgery is the most common, the range of other causes is actually pretty diverse, which is fascinating itself.
Okay, like what else?
Well, for instance, you can have autoimmune causes.
The body attacking itself.
Exactly. The immune system mistakenly targets and destroys the parathyroid glands. Sometimes it happens on its own, just affecting those glands. Or it could be part of a bigger picture, like a syndrome called polyglandular autoimmune syndrome type 1, APS1.
That sounds complicated.
It is. It just means the immune system is causing trouble for multiple hormone glands, not just the parathyroids. And that specific type is often linked to a mutation in a gene called AIRE. A-I-R-E.
Okay. The AIRE gene.
Yeah, it's a gene that normally helps teach the immune system what not to attack.
Interesting. So autoimmune. What else?
Then you've got genetic or congenital causes, meaning people are born with it.
Right.
DiGeorge syndrome is a well-known one. That's a developmental issue, a specific chromosome deletion, actually, 22q11.2.
Okay.
And it can lead to the parathyroid glands just not developing properly or being absent altogether, along with other issues like with the thymus gland.
Wow.
There are also familial types that run in families caused by mutations in different genes related to PTH or calcium sensing. And then there's a really rare one, Kenny-Caffey syndrome.
Kenny-Caffey.
Yeah, it's unusual because it combines the hypoparathyroidism with things like dwarfism and skeletal problems.
Gosh, quite a spectrum.
It is. And less commonly, you might see infiltrative disorders.
What does that mean? Filter.
It means something is building up in the glands and stopping them from working, like iron overload and hemochromatosis or copper buildup in Wilson's disease.
Oh, okay.
Even radiation therapy to the neck, say for Hodgkin's lymphoma, can sometimes damage the parathyroid glands over time.
Right, radiation damage makes sense.
And then there's one more category, which is really important to distinguish. It's called functional hypoparathyroidism, or PTH resistance.
Functional. Okay, how's that different?
So in this case, it's not that the glands aren't making PTH. They usually are, sometimes even a lot of it.
Oh.
But the body's cells The receptors in the kidneys and bones,
Hmm.
they just can't respond to the PTH properly.
Ah, so the signal's being sent, but no one's listening.
Exactly. That's a great way to put it. You see this in conditions like pseudo-hypoparathyroidism,
Hmm.
often due to a mutation in another gene, GNase1. So the hormone's there, but the body can't use it effectively. It's like the key doesn't fit the lock anymore.
That distinction is super helpful. It's amazing how one hormone problem can stem from so many different places.
Yeah.
Surgery, genes, the immune system, even resistance.
It really highlights how interconnected everything is.
Definitely. So, okay, if we connect this back, understanding what PTH normally does helps us see what goes wrong when it's low or ineffective. Can you walk us through that chain reaction inside the body?
Absolutely. So think of PTH as the body's main calcium regulator. Normally, it has 3 key jobs to keep calcium levels just right.
Okay, 3 jobs.
1, it tells the kidneys to hold on to calcium, to reabsorb it back into the blood instead of letting it spill into the urine.
Right, keep the calcium.
2, it signals the bones to release a bit of their stored calcium into the bloodstream.
Calcium from bones, okay.
And 3, this one's critical.
Right.
It helps the kidneys convert inactive vitamin D, the kind you get from sun or supplements, into its active form. Active vitamin D is absolutely essential for us to absorb calcium from the food we eat.
Ah, so PTH is like the activation key for vitamin D.
In the kidney, yes. That's a good way to think about it. So when PTH is low,
Yeah.
all 3 of those processes get disrupted.
Okay.
You get less calcium reabsorption in the kidneys, so you lose more in the urine. You get less calcium release from the bones. And importantly, the kidneys can't make enough active vitamin D.
Which means you can't absorb calcium well from your diet either.
Precisely.
Yeah.
And at the same time, PTH normally helps the kidneys get rid of phosphate.
Yep.
So when PTH is low, phosphate excretion decreases and phosphate levels in the blood go up. That's the hyperphosphatemia again.
Right, the high phosphate. So it's this whole cascade, low calcium coming in, more calcium going out, and high phosphate sticking around.
Exactly. That's the core imbalance.
And you mentioned earlier this imbalance, especially the low calcium, leads to neuromuscular excitability. So
Yeah.
what does that actually feel like for someone experiencing hypoparathyroidism? What are the key things, the symptoms to look out for?
Yeah, the symptoms can be quite dramatic, and they really do stem mostly from that neuromuscular irritability caused by the low calcium. Often the first things people notice are sensations like perioral numbness that's tingling, or a pins and needles feeling around the mouth.
Around the mouth, huh?
Yes. Or paresthesias, similar tingling or numbness, but in the fingers and toes. Muscle cramps are also very common.
Just general muscle cramps.
They can be anywhere, but often in the legs and back. And sometimes you might actually see something called carpopedal spasm.
Carpopedal spasm.
Yeah.
What's that look like?
It's a visible involuntary contraction. The hands might curl inwards, fingers straight but flexed at the knuckles, thumb pulled across the palm, and the feet might point downwards and inwards. It's quite distinct.
Wow, okay. That sounds pretty uncomfortable.
It can be. And if the calcium drops even lower, the symptoms can become much more serious. We're talking about tetany.
Tetany. Isn't that like a sustained muscle lockup?
Exactly. Sustained, often painful muscle contractions. And potentially life-threatening issues too, like laryngospasm.
Laryngospasm, what's that?
That's where the vocal cords spasm shut. It can block the airway, causing difficulty breathing, maybe a high-pitched noise called stridor. It's an emergency.
Yikes. That sounds terrifying.
It is. And seizures can happen too because the low calcium makes nerd cells, including those in the brain, overly excitable.
Seizures too. Gosh. What about other parts of the body? Does it affect the heart?
Yes, absolutely. Low calcium can affect the heart's electrical activity. On an ECG, an electrocardiogram, you might see something called a prolonged QT interval.
Prolonged QT. I've heard that's a risk factor.
It is a significant risk factor for potentially dangerous heart rhythms, arrhythmias. Low calcium can also cause low blood pressure, hypotension, and in really severe or chronic cases, it can even contribute to heart failure.
Okay, so muscles, nerves, heart, anything else?
Yeah, there are other effects too. Many patients report psychiatric symptoms, things like anxiety, depression, irritability, even problems with concentration and memory, sometimes called brain fog.
Brain fog. That makes sense if the nerves aren't firing right.
It seems related. And then there are changes you might see more gradually over the longer term. Things like dry, scaly skin, brittle nails, sometimes hair loss.
Yeah.
And importantly, cataracts can develop in the eyes. That's a well-known long-term consequence of chronic hypocalcemia. Also, dental problems like enamel defects or teeth erupting late, especially if the condition started in childhood.
Wow. It really affects almost every system, doesn't it? From mood to muscles to your teeth.
It really demonstrates how fundamental calcium balance is for the entire body.
Okay, so with this huge range of symptoms, some quite subtle, some very dramatic,
Hmm.
are there any specific physical signs a doctor might look for? Something they can test right there in the clinic?
Yes, absolutely. There are two classic observable signs that healthcare providers often check for. They can provide really vivid, immediate physical evidence of low calcium, of hypocalcemia.
Okay, what are they?
The first is called Chvostek's sign, Chbostek.
Trostick's sign.
Right. For this, you gently tap on the facial nerve, just in front of the ear. In someone with significant hypocalcemia, you might see an involuntary twitching of the facial muscles on that same side of the face, like the corner of the mouth or the eyelid might twitch.
Just from tapping. Wow.
Yeah, it shows the nerve's hyperexcitability. The second one is Trousseau's sign, Trousseu.
Trousseau's. Okay.
For Trousseau's, you use a blood pressure cuff on the arm. You inflate it to a pressure above their systolic blood pressure so it cuts off arterial flow temporarily, and you keep it inflated for about, say, 3 minutes.
Okay. What happens?
If the person has significant hypocalcemia, their hand on that arm will go into that characteristic carpal spasm we talked about earlier.
The curled up hand thing?
Yes, often called the obstetrician's hand posture. Wrist flexed, fingers extended but flexed at the main knuckle, thumb pulled across. It's quite dramatic when you see it.
Those sound like pretty clear indicators.
They are. They're classic signs taught in medical training because they're so strongly associated with hypocalcemia.
Okay, so you've got this wide range of symptoms, these potential physical signs. How do doctors actually nail the diagnosis? What are the definitive tests?
Right, that's a really important question. Pinpointing the diagnosis really comes down to specific laboratory findings. Blood tests are key.
Okay.
You're going to look for decreased serum calcium. That's both the total calcium level and, perhaps more importantly, the ionized or free calcium. That's the biologically active form.
Low calcium check.
At the same time, you'll usually see increased serum phosphate, the hyperphosphatemia we mentioned.
High phosphate check.
But here's the crucial piece, the linchpin of the diagnosis. The parathyroid hormone level itself, the PTH level.
Right. What about it?
In true hypoparathyroidism, the PTH level will be either frankly low or, and this is really important, it might be inappropriately normal.
Inappropriately normal. How can normal be inappropriate?
That's the key. If your blood calcium is low, your body's normal response should be to crank out lots of PTH to try and fix it. Your PTH level should be high.
Ah, okay. I see.
So if your calcium is low, but your PTH is low, or even just in the normal range, that's not a normal response. It's inappropriate.
Yeah.
It tells you the parathyroid glands themselves aren't responding correctly. They're the source of the problem.
That makes perfect sense. So a low or normal PTH when calcium is low is the smoking gun?
Exactly. That's the hallmark. Beyond those core tests, you'd also typically find decreased calcium levels in the urine because the kidneys are trying desperately to hang on to whatever calcium they can.
Makes sense.
And you'd likely see decreased levels of that active form of vitamin D, the 1025-dihydroxyvitamin D, because PTH is needed to make it.
Right, the activation step.
And ECG is also important, as we discussed, to look for that prolonged QT interval, that heart rhythm risk. And in some cases, maybe genetic testing if a congenital cause is suspected, particularly in kids or if there's a family history. And sometimes, though less common for diagnosis itself, brain imaging, like a CT or MRI, might be done, especially in chronic cases. It can sometimes show calcifications, little calcium deposits, in a part of the brain called the basal ganglia.
Calcification in the brain. Does that cause problems?
It can, especially if it's extensive. The basal ganglia are involved in controlling movement, so over time, these calcifications can sometimes contribute to movement disorders, like Parkinsonism-like symptoms.
Wow. Okay, so once the diagnosis is confirmed with these tests, what's the plan? What's the path forward for managing hypoparathyroidism? Is it curable, or is it more about long-term management?
For the vast majority of people, especially those with post-surgical or genetic causes, it's definitely about lifelong management. It's not typically something that can be cured in the sense of making the glands work perfectly again.
Okay, lifelong. So how is it managed day to day?
Well, the approach really depends on the situation. There's managing an acute, severe drop in calcium, which is an emergency.
Right, like with tetany or laryngospasm.
Exactly. And then there's a chronic, long-term day-to-day management.
Okay, let's start with the emergency. What happens then?
For acute, severe hypocalcemia, the priority is to get calcium levels up quickly and safely. This usually involves giving calcium intravenously, IV calcium. Typically, it's calcium gluconate, usually a 10% solution, given as a slow infusion.
Slow infusion, okay.
Yes, giving it too fast can be dangerous for the heart. If the symptoms are really severe or persistent, a continuous IV infusion might be necessary for a while. And crucially, you need constant cardiac monitoring, watching the ECG because of that risk of arrhythmias when calcium levels are changing rapidly.
Right, makes sense. Critical care.
Absolutely. But then once the acute crisis is over, or for someone diagnosed with chronic hypoparathyroidism, the focus shifts to long-term management.
Okay, what does that involve?
The cornerstones are oral calcium supplements, usually calcium carbonate or calcium citrate, taken multiple times a day.
Just regular calcium pills.
Yes, but often at fairly high doses. And, this is really key, they also need active vitamin D.
Active vitamin D again, not just the regular kind.
Correct. Forms like calcitriol or alpha-calcital. Remember, because PTH is low, their kidneys can't activate the regular vitamin B, like ergocalciferol or coolcalciferol, effectively.
Right. You have to bypass that broken step.
Exactly. You give the body the form of vitamin D that's already active, so it can directly help absorb calcium from the gut. This combination of calcium and active vitamin D is fundamental.
Okay, calcium and active D. Anything else?
Sometimes, yes.
Yeah.
Magnesium levels need to be checked and corrected if they're low.
Why magnesium?
Because low magnesium, hypomagnesemia, can actually interfere with both the secretion of PTH and the body's ability to respond to PTH. So if magnesium is low, it's much harder to correct the calcium. You need to fix the magnesium first.
Got it. Magnesium's important too.
And sometimes doctors might use a thiazide diuretic, like hydrochlorothiazide.
A diuretic, doesn't that make you lose fluid and salts?
It does. But thiazides have a specific effect in the kidney tubules. They actually reduce the amount of calcium loss in the urine, so they can help the body hold on to calcium.
Oh, interesting. A kind of counterintuitive effect there.
A little bit, yeah. And finally, dietary modifications are usually recommended.
Like what kind of diet?
Generally, a diet that's high in calcium, but relatively low in phosphate.
Low phosphate. What foods are high in phosphate?
Things like dairy products, unfortunately, could be quite high. Also, processed foods, colas, some meats and nuts. So patients often work with a dietitian to figure out how to maximize calcium intake while minimizing excess phosphate.
That sounds like a bit of a balancing act.
It really is. Managing hypoparathyroidism effectively is definitely a continuous balancing act.
So it's not just about taking pills, but also managing diet and potentially other medications. You mentioned it's lifelong management. How closely do patients need to be monitored? What are the doctors checking for?
That ongoing monitoring is absolutely crucial. It's not a set-it-and-forget-it situation. Patients need regular blood tests.
Oh, regular.
It varies, but often every few months, sometimes more frequently if things are unstable. They'll check the serum calcium, serum phosphate, kidney function, usually by measuring creatinine.
Okay.
And also the amount of calcium being excreted in the urine, often with a 24-hour urine collection.
Why check urine calcium if they're taking calcium supplements?
That's a really important point. The goal of treatment isn't just to get the blood calcium level back into the normal range. In fact, you usually don't want it at the high end of normal.
Oh, why not?
Because if you push the blood calcium too high with supplements and active vitamin D, especially without PTH working properly, you can end up forcing too much calcium into the urine.
And that causes problems.
Yes. Over the long term, high urine calcium significantly increases the risk of developing kidney stones and nephrolithiasis, or even more widespread calcium deposits in the kidney tissue, called nephrocalcinosis, which can damage kidney function over time.
Ah, okay. So you're trying to avoid kidney damage.
Exactly. So the target for serum calcium is usually in the low normal range, say around 8.0 to 8.5 milligrams per deciliter, maybe slightly higher depending on the person, but definitely avoiding the higher end of the normal range.
So it's a delicate tightrope walk. Enough calcium to prevent the low calcium symptoms, but not so much that you cause kidney problems down the line.
That's precisely it. A constant balancing act, managed through careful monitoring and adjusting doses of calcium and active vitamin D.
That's fascinating. It really changes how you think about normal ranges. So, thinking long-term then, with this lifelong management, what is the outlook? And what are the main complications people need to watch out for, even with treatment?
Well, managing the condition long-term, even with the best efforts, means being vigilant for potential complications.
Yeah.
As we just discussed, chronic kidney disease is a major concern, resulting from those kidney stones or nephrocalcinosis due to the long-term treatment itself.
Right, the kidney issues.
Those basal ganglia calcifications in the brain we mentioned earlier. They can sometimes progress slowly over years, even with treatment, and potentially lead to movement disorders later in life.
Okay.
Cataracts are also quite common in the long run. And those dental abnormalities if the condition started early. In children, if it's not optimally managed, it can unfortunately affect growth, leading to growth retardation.
So quite a few potential long-term issues to monitor.
Yes. But, having said that, the overall prognosis, the outlook, is generally good if the condition is properly diagnosed and managed with consistent calcium and active vitamin D therapy and careful monitoring.
So people can live relatively normal lives.
Absolutely. People can live full, active lives. It requires diligence, regular medical care, and adherence to treatment. But the prognosis is good with that support.
That's reassuring. What about if it's not treated?
Well, that's a very different story. If left untreated, severe hypoparathyroidism has a poor prognosis. The risks of uncontrolled seizures, severe heart rhythm problems, heart failure, laryngospasm, these can be fatal. So diagnosis and consistent treatment are absolutely essential.
Underscores the importance of getting that diagnosis right. Now, you mentioned earlier that other things can cause low calcium. How do doctors make sure it is hypoparathyroidism and not something else presenting similarly? What's the key differentiator?
That's an excellent question because you're right, low calcium can happen for various reasons. It's called the differential diagnosis. But the absolute key, the single test result that usually separates true hypoparathyroidism from most other causes of hypocalcemia is the PTH level itself.
Back to the PTH level again?
Exactly. Let's take pseudohypoparathyroidism, the PTH resistant state we talked about. Calcium is low, phosphate is high. Similar symptoms. But the PTH level will be high because the glands are working overtime trying to get a response.
Right. High PTH and pseudo.
In simple vitamin D deficiency, you'll have low calcium, maybe low phosphate too. But again, PTH should be high as the body tries to compensate for the poor calcium absorption.
High PTH and vitamin D deficiency too.
Chronic kidney disease often causes high phosphate and low calcium, kind of mimicking hypoparathyroidism. But again, because the kidneys aren't working well and also can't activate vitamin D properly, the PTH level usually becomes very high. That's called secondary hyperparathyroidism.
High PTH in kidney disease. It's a pattern.
It is. And even with severe hypomagnesemia, low magnesium, which can impair PTH secretion. Fixing the magnesium usually allows PTH to recover. The primary problem isn't the parathyroid gland itself in that case.
So in almost all these other cases that look similar, the PTH is high, trying to respond. But in true hypoparathyroidism, it's low or inappropriately normal because the glands themselves are the problem.
You've got it. That PTH level in the context of the calcium level is really the diagnostic cornerstone.
That's incredibly clear now. Okay, so let's try and recap the main points from our deep dive today. Hypoparathyroidism means your body has low or maybe even absent parathyroid hormone, PTH.
Right.
And that lack of PTH directly causes low calcium and high phosphate in the blood.
The core biochemical problem, yes.
The number one cause, by far, is post-surgical damage or removal of the glands, often during thyroid surgery.
Most common, definitely. Though autoimmune, genetic, and other causes exist too.
Right. And if someone has an acute, severe drop in calcium, that's an emergency needing IV calcium.
With careful monitoring.
But for the long haul, treatment is lifelong and relies mainly on taking oral calcium supplements and, crucially, active vitamin D.
That active vitamin D is key, bypassing the step that requires PTH. And just to reiterate, that careful, lifelong monitoring, checking blood calcium, phosphate, kidney function, urine calcium, it's absolutely paramount, not just for managing symptoms, but really for avoiding those serious long-term complications like kidney damage or brain calcification. It's all about maintaining that delicate balance.
Maintaining that balance. So what does this all mean for you listening?
Well, hopefully it gives you a real appreciation for the incredibly delicate dance of hormones in our bodies and how truly vital even the tiniest glands like these little parathyroids really are.
They punch well above their weight, so to speak.
They really do. Their impact is anything but small. So maybe next time you hear about someone having thyroid surgery or you just think about how your body works, you might just remember those tiny parathyroid glands tucked away nearby. Remember that critical dance they perform with calcium, keeping everything humming along? Silently, but powerfully.